सभी का ख्याल रखते हो। बस लक्ष्य है सेवा, सेवा से कभी ना थकते हो। नहीं जान की परवाह, निकले हो जान बचाने को। तुम रोक ही लोगे आंधी जो है आने को। शुक्रिया भारत के योद्धाओं, एमक्योर करे सलाम आपको। शुक्रिया भारत के योद्धाओं, एमक्योर करे सलाम आपको। कैसी ये जंग है, पड़ी मौत सांसों के पीछे। बने तुम जो मसीहा, जगी जिंदगी में उम्मीदें। वहाँ वीर खड़े हैं उन सरहदों की रक्षा में। यहाँ आप डटे हैं इंडिया की सुरक्षा में। शुक्रिया भारत के योद्धाओं, एमक्योर करे सलाम आपको। शुक्रिया भारत के योद्धाओं, एमक्योर करे सलाम आपको। एमक्योर करे सलाम आपको।
Good evening, warm greetings. I'm Dr. Onkar Swami on behalf of Pharmaceuticals Limited. Welcome you all in this HIV Updates Symposium organized in collaboration with Chennai Antiviral Research and Treatment. So friends, in last month, we have witnessed a virtual AIDS 2020 conference. And interestingly, the key clinical studies related to ART from AIDS 2020 will be discussed in this symposium with a very powerful and senior faculty, Dr. N. Kumarasamy sir. It gives me an immense pleasure to welcome our faculty, Dr. N. Kumarasamy sir. I personally feel this session would be a much interesting as senior faculty lecturer will be participating in this clinical update and sharing some of the important clinical updates from AIDS 2020. It's my pride, privilege, and honor to welcome Dr. N. Kumarasamy sir and introduce sir. Sir is currently Chief and Director of VHS Infectious Disease Medical Center at Chennai, India. Sir is also Director and a site leader for the Chennai Antiviral Research and Treatment Clinical Research Site of US National Institute of Health, which conducts a multi-site therapeutic and preventive clinical trials in infectious disease, which also includes COVID-19. Sir has been a part of a clinical investigator team for several ongoing clinical research projects with University of California, San Diego, Brown University, Harvard University from Boston, New South Wales University, and Cribbay University, Sydney from Australia. So from US, very far west to the Australia east, sir has been collaborating to various universities for clinical research. Sir has been a clinician and researcher in infectious disease with more than 25 years of experience, and very interestingly, more than 400 manuscripts is on his credit. Sir has been an advisor and expert panel for WHO ART treatment guidelines committee and a critical advisor to the Clinton Health Access Initiative. Sir has also been on the ICMR National Task Force for the clinical research on COVID-19. Thank you very much, sir, sparing some time for today's symposium. And I feel that under your leadership, this symposium will be the very great interest, and we will learn many new things which has happened in recent past, and what are the things which is coming in recent future. So with this introductory note, I would like to once again welcome formally to our speaker, and would like to hand over this session to sir. Sir will be speaking on clinical updates from AIDS 2020. Over to you, sir, and I beg your pardon.
Sure. Can I start sharing my screen?
Yes, sir.
You're able to see my first screen?
Yes, sir.
Can you hear me well?
Yes, sir.
Okay. Good evening, everyone. So it's my pleasure and honor to speak to you today on the clinical impact of the new data, which has been recently released at the AIDS 2020 virtual AIDS conference, which many of us in the last 2 decades who are always loved to attend, we have attended that. But because of this unfortunate pandemic, we couldn't be at the International AIDS Conference, which was scheduled in San Francisco, but happens virtually. A few of us would have seen some of those sessions virtually because of the time difference, and we have been on the other side of the planet. Many of us, couldn't view all the sessions. So today, to fill the gap, this meeting was organized in collaboration with the Chennai ART Symposium, which many of you attend every year. This year again, we couldn't organize this, and it's going to be purely a virtual. A couple of months back, I spoke to you all about the new data which was released at the CRI 2020 virtual conference. And today, I'll be speaking to you the one on AIDS 2020, which has been organized by International AIDS Society, virtual. Again, I'm not trying to walk you through the whole conference, which happened on 4 days and with several presentations. But I'm going to talk to you key stuff on the antiretroviral scenario, especially for clinicians, it will be useful. And also, I will also give some snippets and what will probably make it to resource limited settings in terms of getting into these guidelines. As many of you know that this is the DHS's guidelines and IAS USA guidelines, which are being followed up in research-rich settings, particularly in North America, in Europe and other research-rich settings, where they clearly recommended, again, integrase inhibitor containing combination, either with the dolutegravir TAF FTC or TDF FTC with dolutegravir or with the TAF FTC and bictegravir. Also, in the recent guidelines in the West, they also recommended a combination of a 2-drug strategy that is on with dolutegravir and 3DC for patients with HIV who got the viral load of less than 500,000 copies who are not being, who don't have hepatitis B. Similar recommendation are also been done by the IAS USA guidelines, which again been practiced widely in the North America as well as in the Europe. WHO recommendations last year, which many of you have been very familiar with, and also I have spoken to you in the past on this, were again very clearly recommended with a combination of tenofovir, lamivudine, and dolutegravir as a preferred, and as an alternate in places where they don't have dolutegravir or for some reason where you can't use dolutegravir, you can use the efavirenz of 400 milligram based on the Emcure study. Also, the recent WHO guideline, I won't use the word recent because which might be a little updated in the next couple of months' time, also very clearly said that the efavirenz 400 is out of the box. So in your practice, if you have anyone, I think it's time to move them to dolutegravir containing therapy. And also, the guidelines also recommended a TAF containing therapy, TAF with 3DC or with FTC with dolutegravir for a special population. What are those special populations? Who are elderly people who are prone to develop kidney disease or bone disease, or who can develop any type of kidney disease in futures, where this particular combination recommended. Also, I spoke to you a couple of months back that there is a study being done by the pediatric network called Impact, where also have shown reducing the dosage of TAF has also been beneficial in children, which again in the future guidelines will strongly recommend on that. So today, what I'm going to speak to you is, from the update of this International AIDS Conference, what had impacted probably on these guidelines, and as well as some of those newer regimens which can also be included. Also in these guidelines, also very clearly recommended dolutegravir can be given in pregnancy, where initially, there were reports showing about neurotube effects, but now the last guideline clearly recommended. I will also walk you through some of the new data being presented in that particular scenario. So today, the outline of my presentations today in the next 35 to 40 minutes is what happened to the current ART and what happened to the metabolic effects of the currently used antiretroviral treatment. Also, a couple of new investigational HIV treatment strategies which may make to the guidelines, may not be today or tomorrow, might be in the, with the next couple of years. And what's new in HIV prevention in terms of biomedical prevention. And I'll end up just walking through COVID-19 and HIV, which many of you might be very interested in, maybe practicing, in your settings. So coming to this current ART, I'm just going to walk you through about these guidelines for pregnancy in terms of antiretroviral therapy. Many of you have been aware that, and also I spoke to you all in the past in such webinars, a study called SEPAMO study, which has been an ongoing observational study in Botswana among women who have been initiating antiretroviral treatment and becoming pregnant and delivering. They closely monitor them for years and years. So this particular group in the year May 2018, showed some sort of a signal stating that dolutegravir can produce a neural tube defect, and following that, we didn't recommend, in that population. This is a couple of years back. So soon, a year later, in April 2019, the same group, when they continued this study as an observational study among women who have been delivering or initiating dolutegravir and subsequently become pregnant, where they said that the prevalence of neural tube defects have been going down and was almost been comparable to the non-dolutegravir containing ART. So that particular signal was removed, but on the other hand, guidelines also very clearly recommended in the past, you have to give this choice to the women to choose whether dolutegravir will be good for them or you have to choose an alternative. So in this particular conference where they presented virtually the updated analysis up to April 2020. So what are those analysis? Again, for people who are not much familiar with this SEPAMO study, so this is an observational study, it's an ongoing study in Botswana, where they compare pregnant women who are on antiretroviral drug against different regimens. So in this particular analysis, they compared dolutegravir, which has been recommended by WHO, versus non-dolutegravir containing regimen versus the former standard of care that is being efavirenz. So you can see the numbers is quite a large study. So in April 2019, they showed that the prevalence of neural tube defects have come down as compared to 2018. And now in April 2020, if you see this difference, it's been much further come down. So they've said that it's almost been comparable to the non-dolutegravir containing therapy. So that means it's becoming safer. Today the study very clearly reiterates that dolutegravir containing antiretroviral treatment, it's been safer in pregnancy in the context of neural tube defects, which the signal was given a couple of years back. Were relaxed last year with some caveats, but now very clearly show that it's been much safer. So, and the group also concluded stating that from the initial analysis, May 2018 to April 2019, the prevalence of neural tube defects came down from 0.94 to 0.30, and currently in 2020, in April 30th, they have shown is 0.19 versus 0.11 against the non-dolutegravir containing therapy, stating that today dolutegravir containing therapy has been safer, for pregnant women in the context of neural tube defects. So moving to these metabolic effects of the current antiretroviral treatment, again, a couple of months back, I spoke to you all in a similar webinar about a study, which was being carried out in South Africa called Advanced Study, where they have shown the efficacy of these three different regimens, where they have shown that it's been comparable in terms of efficacy between the three arms. This is a three-arm large multi-center study. It was started as a multi-center, but it was conducted as a single site finally because of various regulatory issues. And it was a phase 3 trial. And it was a three-arm. That is, one is a standard care of arm at that time was tenofovir, FTC, and efavirenz, which was compared against tenofovir, FTC, and dolutegravir versus TAF, that is tenofovir anifetamide, with FTC, emtricitabine, and dolutegravir. So in this particular study, at week 192, the group have shown very clearly that it's been comparable in terms of different groups in terms of the virological suppression. But in this particular conference, virtually, they also showed some of those metabolic effects of these different regimens. Particularly, they compared TAF against other regimens. So they have shown that particularly in women who have been enrolled in the study, this is in South African Black women, where they gained weight, predominantly more fat mass than lean mass. It's been seen significantly in women as compared to men. Again, you can see in this particular table the significance between women versus men, both in terms of all the groups, and particularly in the arm between TAF, FTC, and dolutegravir, which has been very highly significant. And following that, there are a lot of concerns being raised, which again speak to you, which I spoke to you in the past. So again, when this data was compared with a lot of other data, which I'm going to walk you through, one of the very large observational database called Opera, which they collect data from different clinics across the globe, particularly in the US. And currently, our clinic here in Chennai also participate, but this particular analysis has got mostly data from the United States. So what they've shown in this particular analysis is they compared among patients who are being changing from tenofovir to TAF with the different antiretroviral regimen, either with integrase inhibitors or NNRTI or boosted PIs, and they did a different weight gain analysis. And again, these are the patients who had an undetectable viral load on at least 2 times with a viral load of less than 200 copies. So what they've seen in this particular analysis, which is very important as a clinician's perspective. So where if you see this, when they change from tenofovir to TAF, which many of us, we change our patients because, as you know, that TAF is more safer to the kidneys as well as to the bones, especially when patients are on long-term antiretroviral therapy. We prefer to have safer antiretroviral treatment options to our patients. So again, when it's been compared, combined along with an integrase inhibitor, you can see how this weight gain over a period of time is shown in these x-axis, in y-axis, x-axis is in duration of follow-up. If you see this NNRTI, particularly the efavirenz, again, you can see this weight gain when they change from TDF to TAF, and also with the boosted protease inhibitors. That means you're seeing this weight gain across all different regimens, not just with the integrase inhibitor alone. So, but if you see these, the bottom chart, if you see this, what I'm highlighted here as in red color, now over a period of 0 to 9 months, if you see this is weight gain of 2.64 kilograms with the integrase inhibitors and 2.25 with NNRTI. So that means not just alone with the integrase inhibitor when you change from a TDF to TAF, but also with the NNRTI. So that means TAF might be a significant factor in terms of weight gain, not just dolutegravir or other integrase inhibitor alone. Again, the same group also compared different integrase inhibitors. As you all know, that we have dolutegravir, we have raltegravir, which we used a lot in the past, as well as in the West, they have what is called elbitagravir, which needs to be boosted with a drug called kirbicistat. Again, when they compared across these 3 different integrase inhibitors among patients who had switched from TDF to TAF, again, if you look into the weight gain changes, it's more being seen with elbitagravir, and next with raltegravir and with dolutegravir. So that means all these integrase inhibitors, also causes, not just one particular integrase inhibitors like dolutegravir, which many clinicians used to have a concern on it. It's been across all integrase inhibitors. And it's very clearly shows that TAF itself, it's an independent risk factor for this, weight gain. Now, moving to, do we have other alternate drugs? Of course, we have TAF, which is needed. So instead of this dolutegravir or bictegravir or elbitagravir, can we have, as an other NNRTI? Now, as we all know that now we have a new NNRTI recently approved by the US FDA called doravirine, which is a 2nd generation non-nucleoside reverse transcriptase inhibitor, which also works against many resistant strains to other NNRTI like nevirapine and efavirenz. So this particular study called DriveShift, where they compared initially a combination of tenofovir, 3DC, and doravirine against efavirenz or darnur-based regimens, where they have shown comparable efficacy. Again, in this particular study, and they presented in this AIDS 2020 virtual conference, they did these metabolic analysis, particularly with the weight changes after they switched to doravirine-containing therapy among patients who have been virologically suppressed. So what is this particular DriveShift study? Again, this is the schematic structure of this study. These are the patients who have been adults with HIV RNA less than 40 copies, for at least on 6 months with ART, we are being stable, and their eGFR is more than 50 ml per minute, no prior virological failure or resistance. 670 patients been recruited for the study, 2-arm study. One arm continued the same regimen where they have been on, and another arm, been randomized to a combination of and doravirine. So again, this study at week 24 for the patients who are continue to have a baseline suppressed viral load, they are also been moved to doravirine, tenofovir, and 3DC containing therapy, and the study went up to 144 weeks. Again, primary endpoint of this study was been HIV RNA less than 50 copies at week 48 in terms of immediate switch arm versus week 24 in a delayed switch arm. It's a very interesting study. And again, this particular analysis looked into those weight measurements recorded at every study visit, and outcomes are analyzed separately for patients who are immediately switched to doravirine with 3DC and tenofovir versus a delayed switch at week 24. And again, this also been subsequently further sub-analyzed, especially for percent of weight gain and as well as change in BMI. In these line graphs, if you see this, there is a modest weight gain both in the immediate switch as well as in the delayed switch patients. If you see this in the first 6 months, you can see anything from 0.6 to 0.7 kilos in both arms, as well as when you see from 6 months to 1 year, again you see similar weight gain, and again over a period of time in both the switch arm. So these particular investigators concluded this particular study stating that there is a mean weight gain of 0.5 to 0.7 kilos at 6 months post-switch, 0.7 to 0.8 kilos at 1 year, and around 1 to 1.4 kilos after 2 years. So again, trend towards reduced weight increase from integrase inhibitors when compared to protease inhibitors and NNRTI. Also in this particular study, they've seen a significant weight gain, especially more than 10% in a small minority of the patients. This has also been seen in the advanced study, particularly in South African Black women, group of women where they saw huge weight gain. So this clearly shows that this type of weight gain is something related to gene specific, where again further investigations are being needed. You cannot use these data on weight gain for generalize on everybody. You need to closely monitor these patient population who are on TAF or in containing therapy. So moving to these metabolic aspects, 2 drug strategies. And again, this particular drug combination called 3AC-TG, which is called Devato, US FDA approved last year for use, especially even to initiate treatment for people who have got less than 500,000 copies, who don't have TB and hepatitis B. And also people who are already being suppressed, then you can move them to these containing therapy if they don't have hepatitis B or they don't have resistance to 3DC or integrase inhibitors. But again, it's not recommended in hepatitis B and as well as in TB co-infected patients. So in this virtual AIDS 2020 conference, they also showed the metabolic changes they have seen following switch from the 3-drug strategy to 2 drugs in a study called TANGO study. So what it is, TANGO study is an open label phase 3 non-inferiority study where they switch the patients who are on 3-drug regimens to 2 drugs, and they compared this among a group of patients who continued the 3-drug on their own. So, and they found that these particular 2-drug strategies been non-inferior in terms of virological suppression. And again, they did a sub-analysis, a metabolic analysis in terms of weight changes between the arms after switching to 2-drug therapy. And also they looked into a variety of other parameters like fasting glucose, fasting insulin, geometric mean HOMA-IR, insulin resistance, and other metabolic syndrome at week 48. And again, in this particular sub-analysis, you can see these, there are some significance seen when you compare this 2-drug strategy with the 3-drug strategy with the TAF along with dolutegravir and 3DC, where you can see these changes in terms of geometry, HOMA-IR, and as well as fasting insulin, different groups. And again, these investigators concluded and stating that you have two-drug strategy, which favors in terms of adjusted, there's an odds ratio adjusted for insulin resistance, but on the other hand, when they looked into the metabolic syndrome, and again, people who are on TAF, they have, more events, but again, it was not statistically being significant. So again, this two-drug strategy will become popular. It's already been getting popular in the US and in Europe and research settings. But in research limited setting, now clinicians have been talking about how we can drop a drug when someone is being suppressed, where again, we can take the learnings from this particular study that, again, changing from 3 drugs to 2 drugs have led to smaller increase in weight, but overall improvements in other metabolic health parameters, which is very important, in our patients who are living longer with these medications. More pronounced differences favoring the doctor with 3DC arms observed in the boosted subgroup for lipids and fasting insulin and insulin resistance. What do you mean by this boosted subgroup is, this also had patients at baseline who have received boosted protease inhibitors, who subsequently who have been switching, to these 2-drug strategies. And also in the unboosted group, there was a trend observed in favor of, again, this 2-drug strategy for the prevalence of metabolic syndrome at week 48, although this did not reach significance. Again, it clearly shows that it's been very promising. I think this is something what we should use it in our clinical practice when these 2-drug combination as FTC is getting available in resource limited setting for those patients who are already have well suppressed, who have got a risk to, metabolic syndrome and other, comorbidities. Now, moving to the new investigational HIV treatment strategies. Again, in this conference, there has not much been discussed except a couple of things I thought probably might even make it to the resource limited setting after maybe a couple of years. So one such drug is a very interesting drug. I think I spoke to you all a couple of months back from a data being presented at CROI, where now they presented a little more on updated data and as well as these analysis on a 2-drug strategies. So what is this new drug? Is a drug called Latravir, which is again, it is a translocation inhibitor. I'll talk about that soon, which is combined along with the doravirine, which is a newer 2nd generation doravirine, now approved for use by the US FDA, along with the lamivudine. So again, they gave these 3 drug combination as an induction, and subsequently when they are suppressed, they drop to one of the drug and a combination of Latravir and doravirine for maintenance. Again, I'll be talking to you more about the maintenance, how it had maintained this virological suppression. So what are those 2 new drugs? One is doravirine, which I talked to you earlier. Again, it has been active against a variety of NNRT resistant strains and very attractive molecule. Now it has been approved by US FDA, but not been tested against TB, rifampicin interaction, and as well as in pregnancy. At this time, we don't have much data on that, but again, it has got a very powerful drug, especially patient who got other pre-existing NNRT resistance. And what's the other key drug which was used in this particular study is what is called Latravir. It had a name called MK8591 or EFTA. It is a novel NRTI translocation inhibitor. So what is good about that is it's been highly active against HIV 1 and 2, especially at the reverse transcriptase level by preventing the translocation. So what is this particular translocation is? It is something like a 2-punch in containing this virus replication on 2 mechanisms. One, it stops the reverse transcriptase a nucleoside binding site from opening, and another one is a delayed chain termination, which prevents the nucleotide incorporation into the viral DNA. This 2-punch against this HIV may contribute this particular drug, which can be a very high potent as compared to various other drugs which we have used. And again, another one thing attractive about this drug is it will also work against resistant strains to tenofovir, which we use a lot in our 1st-line and 2nd-line therapy. Again, this particular drug works against K6PR and the Q151M complex, which are key mutation for other NRTIs. And again, this drug was also been tested as an injectable form, also been available for an oral form, which I'm going to talk to you about soon. And also, they have also shown that it has got a little longer half-life, up to 10 days, and also accumulate in various other different tissues, lymph node, vagina, and rectum. Hence, it can also be tested in future for as a pre-exposure prophylaxis or as a post-exposure prophylaxis. So in this particular study called PO11, What's the background is, they use these two different drug strategies, which I talked to you about this earlier. And again, in this particular presentation, they presented the maintenance strategy with Latravir with Doravirine as a maintenance therapy among patients who had virological suppression on 3-drug therapy. Again, this particular therapy is an ongoing phase 2 study comparing efficacy and safety of different doses of Latravir with Doravirine following an induction with 3-drug combination with the 3DC along with these 2 drugs for 24 weeks versus tenofovir with 3DC and Doravirine. Again, this particular analysis which I'm going to talk to you about focused on a small number of patients with protocol-defined virological failure. Again, this is a design of this study where again patients who have been ART naive with a load of more than 1,000 copies and with a CD4 of more than 200, they were recruited in this 4-arm study. They were randomized into Latravir with Doravirine and 3DC at Latravir at 0.25 milligrams. Another arm is again the same 3 similar drugs with 0.75 milligram Latravir. Another arm with 2.25 milligram. That was compared against 3-drug strategy with Doravirine, 3DC, and tenofovir. At week 24, when these patients had a suppressed viral load, these first 3 arms dropped 3DC and they maintained with the Latravir with the same dosage with 0.25, 0.75, or 2.25 with Doravirine as once daily oral tablet. And this was compared against tenofovir, 3DC, and Doravirine over a 48-week period. So you can see these bar charts on your left side of your screen, where you can see the comparable efficacy across the different arms. You can see this particular arm with a 2.25 milligram of Latravir have a little lower level of virological suppression. That is because couple of participants in this particular arm had more adverse events and have a poor adherence. And for the reasons that they had virological failure, otherwise all the other arms being very much comparable in terms of these maintenance strategy in these FDA snapshot analysis. Again, when they further looked into those participants who had a virological failure, again at the second assessment to confirm protocol-defined virological failure at less than 80 copies in all patients, with no patients met criteria for resistance setting. That means they had very low level viremia and subsequently they got suppressed. And also, there was no evidence of protocol-defined virological failure or associated with these drug, pharmacokinetics. And again, when they looked into those individual patients who had a protocol-defined virological failure, 3 out of the 6 patients who switched to new regimens had very low-level viremia at 42 days of follow. This very clearly shows that this 2-drug strategy with Latravir, Doravirine, after an induction with 3DC, being comparable at week 48 efficacy versus tenofovir, 3DC, and Doravirine treatment-naive patients. Very low rate of protocol-defined virological failure, and they all have subsequently got suppressed. No patient met criteria for resistant testing. Again, these 2-drug maintenance strategy with Latravir, which has again been very active against even patients who got tenofovir failure, and Doravirine, which has also been very active against patients who got NNRTI mutations, can be an attractive future option even for resource-limited setting. I think please wait for further data on such strategies. Moving to this next drug as a new drug in this conference, they talked about this novel capsid inhibitor called lenacapavir, which again can be given as a long-acting drug at every 6 months subcutaneous dosing. So this is a phase 1 study. Again, what is this particular drug is? It's a novel first-in-class of selective HIV-1 capsid inhibitor. As clinicians, many of you know in our pathogenesis lectures, we have learned that this capsid is released at the time of entry into the human T lymphocyte, and also at the time of maturation, again, capsid development forms and get matured. So these particular drugs works at both the level, at the time of entry level when the capsid are being released, and as well as also at the time of capsid getting matured. It's a very novel first-in-class of drug. It's been developed by Gilead, and the molecule name is 6207. And again, clinical development as component for a long-acting drug. There is a potential HIV, anti-HIV activity even as a single dose with a subcutaneous administration, easy to administer, even it can be self-administered. Also, oral formulations are also being under development. So in this particular analysis, I'm going to present to you about the PK level of different dosages of this lenacapavir subcutaneously be given over a period of time in healthy HIV negative volunteers. Again, this particular study is a 3-arm study where participants were HIV negative people. 30 individuals been recruited for this study, which is a very interesting randomization in each arm, which is 4:1. So that means in each arm there will be 10 people, and out of those, 8 will have this test drug and 2 will have a placebo. Again, 3 different dosages have been tested. One is lenacapavir at 300 milligram at subcutaneous with a 1 ml preparation, and another arm is same drug at 900 milligram, but again with the 1 ml preparation, and another arm is lenacapavir, again the same drug, 900 milligram with a 1.5 ml preparation, which has been compared against the placebo. Again, the endpoints has been safety, tolerability, and the PK measurements. If you look into the baseline characteristics across different groups, is almost been very similar, even including these ethnicity and as well as the BMI, and also these sex preponderance and as well as the age. Again, when you look into the PK parameters, again, it's a little busy slide, but we want you to all look into this particular mean C max. Again, if you look into these 3 different dosages, if you look into these 900 milligrams, which fared much better than the 300 milligrams. So 300 milligrams may not have the sufficient antiviral activity because of these very lower levels. Again, both these different preparations of 900 milligram, both as a 1 ml and a 1.5 ml, have a good C max. Again, if you look into this particular chart, when they extrapolated those PK values, these x-axis is the duration of follow-up of these healthy volunteers, and y-axis is these drug levels in terms of nanograms per ml. And it was been modeled that for this particular drug, lenacapavir, to work against the HIV isolates, you need to have at least 24 nanograms per ml to suppress a virus. So that is like a cutoff level based on the in vitro studies. So when they looked into the PK of these healthy volunteers, if you look into the 300 milligram arm, which is much lower in terms of the PK, which may not suppress this HIV. But if you look into those 900 milligrams of both the different preparations shown by orange and green, both are being able to maintain that level, and even up to 6 months, beyond even 24 weeks to suppress this. But again, if you look into this very carefully, in the first 2 weeks, there is a little lower level when they give these subcutaneous injections. So that means in the first 2 weeks, there is an area of concern that you may need to give certain type of oral lead-in or other modalities to boost the effect, so that they will have the sufficient effect even at the beginning itself. Then subsequently, after 4 weeks, they're able to get this level beyond 6 months. It's a very attractive drug in terms of long-acting drugs, because it's been subcutaneous and it is a small quantity and can maintain up to 6 months in terms of virological suppression. When they looked into the safety, this drug did not have any major grade 2, 3, or 4 events. No one discontinued because of the adverse events. But on the other hand, they complained about injection site reactions, which has not been very significant across the arms, but it all been resolved after a few days. So that means it is a much safer drug in this particular phase 1 PK study. So the investigators concluded stating that this single dose of lenacapavir, which is a long-acting preparation of novel HIV-1 capsid inhibitor up to 900 milligram, is being well tolerated in HIV-negative volunteers. And again, injection site reactions have been seen in 80% of the patients, are very mild, no major adverse events. But on the other hand, because of the slow initial release, it may need oral PK loading before the first injection, where again, further studies are currently underway. But on the other hand, these results are very attractive for the future clinical use. And these PK data very clearly support the ongoing efforts of a phase 2 and phase 3 trial with this particular lenacapavir oral loading dose, then followed by the subcutaneous long-acting drug. Again, as clinicians now, our patients don't want to take oral drugs again and again. You know, they want something, this type of long-acting drug. Again, these are very attractive molecules. Please wait for the follow-up results. Now, moving into those HIV prevention scenario, again, a very nice study using a long-acting antiviral drug was being presented and showed it's been superior as compared to our earlier oral tablets in terms of as a pre-exposure prophylaxis. As all of you know that the WHO guidelines recommended a combination of tenofovir FTC or 3DC as a pre-exposure prophylaxis for a risky population, particularly MSM and transgender women, and as well as heterosexual men, where this particular drug has shown enormous efficacy across a multiple clinical trial, and following that, it was been recommended as a drug of choice. And a couple of months back at the CRY 2020 virtual meeting, which again, I spoke to you all in the earlier webinar about this particular trial called Discover trial, but also showed a combination with the TAF and FTC, which has been non-inferior as compared to tenofovir and FTC. So what these investigators did is they compared these tenofovir FTC versus this long-acting drug with an injectable cabotegravir, which had earlier shown efficacy in terms for the treatment. Now they have used this for prevention. Again, what is this cabotegravir, which is again an integrase inhibitor, which is also orally been available and as an injection with a half-life up to 40 days. Also, in the past, there is another drug called rilpivirine, which has been available as an oral tablet, have also been developed as a long-acting injection. And again, the combination of these two drugs had shown efficacy in terms of treatment in suppressing this virus and maintaining the virological suppression in a study called LETE-2. And also in trials called Atlas and Flare, earlier been presented in CRY, which I've spoken to you in the earlier webinar, showed that these injectable with a combination of cabotegravir and rilpivirine every 8 weeks, maintains a virological suppression in terms of the treatment. Now here, in this particular study, they used just cabotegravir alone, and which was compared against tenofovir FTC as a pre-exposure prophylaxis, especially among MSM and transgender population on a very large number, almost 4,500 individuals being recruited for this study. This is a 2-arm study. It is a large multinational study. It happened across different continents. In fact, our site in Chennai was initially selected to participate because of the various regulatory delays at the, with the Indian government level. India couldn't participate, but our neighboring countries like Thailand and many African countries and Latin America and the United States participated in this trial. So what they have done in that is they randomized into 2 different groups. One received the standard of care, there is tenofovir FTC. These are HIV negative people, high risk MSM transgender women, where they've been randomized to a test arm with cabotegravir. Again, this particular is a very interesting study. So initially they started with an oral tablet every day to get these drug level up. It's again a placebo-controlled trial. In each arm, there will be placebo, where cabotegravir with a placebo equivalent to like tenofovir FTC. The other arm control with the tenofovir FTC with an placebo of cabotegravir 30 milligram like a oral tablet. At week 5, the oral arm was being moved to a long-acting injectable with every 2 months with the 600 milligram as an intramuscular injection along with the placebo. And again, in the control arm, along with the tenofovir tablet, they also received a placebo of an injectable every, they received every 2 months. So this study was planned for 3 years, and once after 3 years, and everywhere been, planned to move to those standard of care. That was the initial design of this study. So again, now prematurely, they found a very interesting analysis, results. So again, I'll talk about that soon. At the baseline, if you look into those different arms, almost the same. It's been very much comparable between different arms in terms of different characteristics. But if you look into those HIV incidents, which you all will be interested to see, if you look into those test arm, there were only 13 new infections as compared to 39 in the standard arm with the tenofovir FTC, and very clearly shows that injectable cabotegravir is not only been non-inferior, but also showed a superiority, statistically superiority. It met that. It was initially, the study was developed to show the non-inferiority as compared to tenofovir FTC. But when they did the further sub-analysis, now they have demonstrated superiority with this long-acting cabotegravir as compared to tenofovir FTC. Again, you can see this Kaplan-Meier very clearly shows that red color is the one patients who are on tenofovir FTC, and the blue one is on participants who are on long-acting cabotegravir, where it's been hugely significant in terms of preventing this HIV acquisition. Again, if you look into the timing of the incident HIV infections among the cabotegravir arm, out of the 13, if you look into that, 2 before even starting treatment, just before the randomization, they acquired, and 3 individuals in the oral lead-in period, and 5 in these when they received the injectable cabotegravir. In the tenofovir FTC arm, totally 39 had new infections, and 3 before they have been randomized, and 39 is the one who been while at the time of blinded with the oral treatment. This very again clearly shows that arm with the cabotegravir arm is being not only non-inferior but also being superior. When they looked into the adverse events between the different arms, which has not been significant between tenofovir FTC and long-acting cabotegravir in terms of different rates in adverse events, and also and other even diseases in terms of adverse events. When you look into the injection site reactions, and again mild, moderate, and severe site injections have been reported, but again mostly with all mild and moderate. All had no one discontinued any of the drugs because of the injection site reactions. Again, if you look into those people who are on placebo with the placebo drug also been shown with some sort of injection site reaction, stating that it is not that very significant in terms of injection site reactions. But very important points they have looked into that is in terms of weight gain. Again, you all know that integrase inhibitors increases the weight, which we have seen in HIV infected people in our clinical practice as well as in various clinical trials, including in advance. Again, they did this sub-analysis in this particular HPTN 083, which is a study which was funded by US NIH. They have seen, as shown by this blue color bar, where cabotegravir arm, a long-acting injectable, have a higher weight gain as compared to tenofovir FTC. Again, it's just statistically significant. Again, whether this will be a future area of concern, again, further need to be studied. But on the other hand, today, this injectable cabotegravir, which is far superior as compared to tenofovir FTC in terms of prevention as a pre-exposure. And again, it's once in 2 months, again, easy to administer as an intramuscular injection, where people don't need to take this as a oral pill every day. So the investigators concluded this NIH-funded HPTN 083 study, stating that long-acting cabotegravir was significantly superior as compared to daily oral FTC and tenofovir, reducing the incident HIV infection among MSM and transgender women. The risk reduction was almost 66%. It's a huge in terms of these prevention effects. Again, injection site reactions were mild to moderate, as I said earlier. It lasted a few days and all resolved. And again, among people who acquired this virus, now ongoing analysis happened whether any have developed this resistance to this particular drug. Again, there is another study again funded by US NIH called HPTN 084, which is currently ongoing with a similar design in HIV negative cisgender women in Africa. So we need to wait for the results. I think these 2 studies will completely impact the future prevention treatment guidelines. Wait for these results over a period of time. In summary of these antiretroviral sessions, again, it's very clear that new drugs may achieve the goal of fewer medications, less frequent dosing, higher barrier to resistance, activity against multi-drug resistant HIV, as shown by, in this presentation from various different, investigators from their studies. People doing well on current therapy, now these new agents will have a role if they are less toxic, more convenient, especially if they're long-acting or if they have less drugs, offer greater flexibility and result in less stigma, because people don't want to take everyday oral tablet, which is a stigma to take tablets in front of others. People tend to ask, hey, what is the problem? They don't want to disclose their HIV status. And also people who have got difficulty in everyday oral therapy, these long-acting drugs are very attractive, especially if they are can be taken every 6 months, which will be very attractive for our patients. But again, these newer drugs need to be studied in pregnancy. We also need to know how we can reduce the cost so that we'll have ensure access across resource limited setting. Again, this will be our future work in progress. I will be ending my presentation soon now, showing some of the newer data which are presented in the context of COVID-19 pandemic among HIV infected people. Again, I have spoken to you in the past about this impact of COVID-19 in HIV, where again, little data on HIV in COVID-19 has been reported. There are very few case reports, even in our clinic here in Chennai, here at Voluntary Health Services Hospital, in our infectious disease medical center, where we follow very large number of HIV infected people, where we also have a dedicated COVID treatment center. We have seen just 12 HIV infected people with COVID. Right now we have 2 HIV infected people with COVID receiving treatment in our VHS COVID-19 treatment center. Why we are seeing less across different parts of world in HIV infected people? We do not know whether not enough COVID-19 testing being happening among people living with HIV, or whether there could be a defective cellular immunity in HIV infection, which could be a protective factor. There are studies ongoing, or any of those antiretroviral medications they have been taking, whether they have any protective effect, we do not know. It's been a work in progress. So at present, there is no evidence to suggest that there is an increased risk of COVID-19 infection and increased severity of illness among people living with HIV. However, people living with HIV who are not on treatment, any antiretroviral treatment, or who are not virologically suppressed, may have a compromised immune system in terms of low CD4, which can make them as a comorbidity to vulnerable to opportunistic infections and more severe illness. But people who have got suppressed viral load and who do not have a low CD4 count, COVID-19 will be affected in a very similar way like people who are not living with HIV. I'm going to end my talk by showing three data they have been presented in this AIDS 2020 COVID conference. So this is a group of patients who have been receiving treatment in New York, where you know that we had a huge HIV pandemic in the past, and now with the COVID-19 pandemic, where 93 patients who have been HIV positive, who had COVID, who have been managed in a particular hospital, who have been analyzed, and you can see these different markers of CRP who have been elevated in most 100% of people, and fibrinogen, D-dimer, IL-6 all been elevated in these HIV infected people. Again, if you look into those patients of these 93, 72 are hospitalized, 26% of them, that is 19 people out of these 93, they died, and remaining 53, they recovered very well. Again, if you look into those people who recovered versus died, and recovered, if you look into those peak CRP, which is lower as compared to people who died. And again, among these IL-6, again, if you look into the people who died, it has been much higher, and IL-8. And particularly what this particular investigator has seen is people who died had a lower nadir absolute lymphocyte count. So, which we are also seeing in COVID-19 patients who don't have HIV, where the lymphocyte level goes down. Now, the combination of both HIV and COVID, if they have a low CD4 already, if they're not taking the antiretroviral drugs, can be very catastrophic. But on the other hand, if they have good CD4 by suppressing the virus, then we don't need to expect very severe disease. It will be similar like a non-HIV infected people. Again, people who have died in HIV and COVID, they all had a higher CRP, IL-6 and IL-8 levels. This very clearly shows that due to the pathogenesis of COVID-19 disease. Again, another analysis from Bronze, where again, they have seen a huge number of HIV infected people in the past, almost 2% prevalence in 2018, where now they've seen very large number of COVID-19 patients, where again, a very large number of deaths there. Again, these particular investigators, they analyzed 100 people with HIV who received antiretroviral treatment there, and they compared them with 4,500 people who did not have HIV, but all had COVID. So again, if you look into those particular analysis between HIV and without HIV in terms of COVID mortality, we see this intubation where if you see this, there is little significance in terms of between HIV and without HIV, especially if their CD4 cell counts are much lower. Otherwise, they didn't see any major significance on that. I think the carry-home message from these observational studies are all when you have been managing your HIV infected people, counsel them, make sure that they take the antiretroviral drugs well, maintain the CD4, even if they acquire COVID-19, it may not be very severe. But on the other hand, there is another data which has been presented from South Africa, the Western Cape, among their COVID-19 deaths, when they did a retrospective analysis where they found that HIV did increase the risk of death from COVID-19, and especially among people who had uncontrolled HIV. And also, they found that in this particular population who died with HIV and COVID, they had more diabetes and being older. So that means probably diabetes and age might be a risk factor for COVID-19 related mortality, even in HIV infected people. As you know that our HIV infected people live longer and they are being aged, and significant among them are being diabetic. Again, all this will add to the morbidity mortality following COVID-19. So what advice I like to give you all as clinicians who are managing HIV infected people, along with the general advice we give it to our HIV infected people, and the advice which I give to the clinicians is, make sure that the patients strictly adhere to the ART and other OI drugs. Keep, counsel them. Don't change the current effective antiretroviral drugs to from a non-PI drug, for example, from TLD to a protease inhibitor, because initially there was a speculation that protease inhibitors and some of those other PIs like lopinavir will be effective against COVID, which is not true, and we don't have any data on that. So don't change them if they have been very effective. Make sure that they also adhere to those other comorbid medications for diabetes and hypertension, because they are the major risk factors for COVID-19 related morbidity and mortality. And I like to conclude stating that today, in the context of this COVID-19 pandemic, where you have been managing our HIV infected people, make sure that they take the antiretroviral drugs well. There is no compelling evidence for the benefit of hydroxychloroquine. I didn't talk anything in this particular presentation, but all the randomized clinical trials have very clearly shows that it has got no benefit in terms of treatment or prevention from any randomized clinical trials, except some vague anecdotal observation, which is not proved in any RCTs. But on the other hand, hydroxychloroquine can have a lot of interactions with our antiretroviral drugs when you have been giving to our HIV infected people. Again, there is no compelling evidence for the benefit of hydroxychloroquine in COVID management. But on the other hand, we all know that remdesivir reduces the time to recovery in patients with moderate severe COVID disease. Again, remdesivir does not have any significant drug interaction with the currently used antiretroviral drugs, which again, I use remdesivir in my clinical practice in HIV infected people who have COVID. And dexamethasone and steroids from these recovery trials shows which improves survival in COVID-19 patients, which also can be given very safely in HIV infected people, particularly if they are suppressed viral load and good CD4. You don't need to worry them. Use these steroids, either dexamethasone or methylprednisolone, which will save them from COVID-19 mortality. And convalescent plasma may provide benefit in severe COVID-19 disease. At this time, there is no contraindication even in HIV infected people. If there is an indication where if you need to give convalescent plasma in COVID-19, even in HIV, use it. There are several monoclonal antibodies are under development for COVID-19. Some of them which they tried for HIV is also been now repurposed for COVID-19, both for treatment and prevention. Hence, please wait for it. Many of those learnings from HIV medicine now, we have been using those principles in managing, COVID, patients. I like to end my talk stating that the future of HIV treatment and management strategies will be not just putting someone on antiretroviral drug and forget them. Now, we need to closely monitor them, make sure that these drugs are not toxic to them, using these recent advances in terms of reducing the drug dosages or dropping a drug, which we have learned from clinical trials, how we can use those data in our guidelines, which will be the future. And also how we can add some of those newer antiretroviral drugs, which have been less toxic, easy to take, long-acting, which is something, you need to look for it in the future treatment guidelines. Definitely, we'll go for long-acting antiretrovirals, either as an injectable. Also, long-acting orals are under development, as well as implantable, not only for prevention, but also for treatment. Again, I'll stop my presentation at this time and happy to take question. And thank you again for your patient hearing, and stay safe. Thank you very much.
Thank you very much, sir. Very magnificent lecture that we had today evening. You have covered right from the basics of and even dolutegravir in the pregnancy, the metabolic effects of ARTs, drive shift study, two-drug strategy, and some of the investigational drug, and including the injections and newer drugs, and what are the place of newer drugs into the therapy. And importantly, you are being an ICMR member of the COVID-19, your thoughts and your views on COVID was very critical. And it was very interesting for me to know the monoclonal antibodies which are coming for the COVID-19 infections as well. So this is in a short, we have covered almost all the important topics today evening, which has been discussed in AIDS 2020, and some of the topics you thought which is very relevant for the practicing doctors. So I have few questions, sir. I have just shared with you in a chat box, sir. I have already marked you. Hope you have received that, sir. I have few more also, which has been sent personally to me. I'm just sharing with that to you as well, sir.
Right. Do you want me to go through the questions or whatever there and answer them?
Yes, sir. Yes, sir. Yes, sir. That would be
okay. Right. So I think there's a question in pregnant women in third trimester. Can you give TAF as compared to tenofovir? So today, TAF is not recommended in pregnancy. It's been recommended in all the other population. There are studies currently undergoing. So at this time, tenofovir is being recommended. That's been preferred. But on the other hand, dolutegravir is recommended across different stages of pregnancy, as I said from the SAPAMO study. Another question is dolutegravir plus ritonavir boosted darunavir whether this can be used as a treatment regimen for second-line patients. So again, I didn't cover this in this particular because it was more of a International AIDS Society AIDS 2020 update. Currently, there is an ongoing clinical trial where I am one of those principal investigator of the trial. This is for a study called DEP study. Currently been recruiting patients even in our hospital here in VHS in Chennai, in my department, where we are comparing this particular arm with the dolutegravir and darunavir 800 milligrams versus tenofovir 3DC and darunavir or tenofovir 3DC and dolutegravir. This trial has been ongoing. I think we need to wait for these results. So where based on that, this can be recommended. At this time, we don't have a recommendation against 800 milligram. But on the other hand, there is an alternate recommendation for second line based on the second line study, a combination of lopinavir and raltegravir is non-inferior to the other standard of care. Or again, if you extrapolate that instead of raltegravir, now you can give dolutegravir. But on the other hand, can you give darunavir 800 instead of the lopinavir? We do not have evidence on that at this time. We need to wait for the outcome of the DEP study, which we have been currently doing. Probably I may speak to you all probably in a year's time when we have the results out. Other than this, I don't see any other questions. Dr. Onkar?
Yeah, I have two more, sir. I'm just sharing that, sir. Yeah, I've just shared that, sir.
Okay. Can dolutegravir plus tenofovir emtricitabine prescribed in all populations with HIV? Yes. So today the recommendation to initiate treatment is a combination of tenofovir emtricitabine or with the 3AC with the dolutegravir is a preferred therapy. It can be given in all population, and only thing, tenofovir is been bone toxic. It's been toxic to the kidneys. So before initiate, you need to do their creatinine clearance. You need to do a creatinine test, and if the creatinine has been elevated, then you should prefer an TAF-containing therapy, which has been also been recommended in the special population. Otherwise, this particular combination is being recommended in all population. Another question is, are we moving for long-acting injection and leaving orals in future? And again, at this time, these long-acting data are very promising. As clinicians, when we take care of these patients on a long run, when they live longer, patients tend to come and ask us, hey, you don't want to take this tablet every day, and our adherence also been goes down. They tend to missed pills for various reasons. So I think to combat all those, the long-acting will work. So I won't use the word will shunned out of oral therapy. Still our patient religiously take these medications. For them, they may continue to take this. Or people who cannot adhere to the drug, or they cannot take this medication for some reasons or for stigma, then these long-acting, especially every 2 months or every 6 months, will be very attractive. But on the other hand, to do that, they need to come to a hospital to have an injection every 2 months. But today, many of our patients who are well suppressed, doing well, they come every 6 months. So both plus and minuses. So you have to pick and choose what is good for your patient on a long run. But I won't throw away the oral drug. Still will be helpful, but you got to choose what is good for your patient.
So there is another 2 questions, sir. I've just chat box to you, sir.
Okay. So your views on rapid starting ART, what is the initial strategy? I think today we have a guidance from WHO, which has been launched in the year 2017 and early 2018. Anyone who has got HIV, you quickly rule out their opportunistic infections, and if they're perfectly fine and no symptoms, you can start even on the same day. Counsel the patient, and if you have a commitment from the patient, they'll take the drug. You can start on the same day of the diagnosis, what is called same day start. Another one is called rapid start. There is someone who has got any opportunistic infection like tuberculosis or any of those other OIs, you stabilize them and you can start on antiretroviral drugs within 7 to 14 days. This is what is called rapid ART initiation, which has already been in place. Almost all clinicians are practicing. I think you should do that. There are certain studies been done, carried out in different parts of the world. They have seen that if you don't do the same day start or rapid start, you may sometimes lose the patient. They may not come to your clinic, and they'll end up coming to your clinic after several years when they are really sick and they'll get hospitalized. In the meantime, they might also be transmitting HIV because they have been HIV viremic to their partners. So it's better to start them as soon as possible. I think the next question is taking one tablet is not an issue. Many with DM, how many take many a day without difficulty? I don't understand this question. Yeah. So I think taking one tablet is not an issue. So I think this particular doctor has asked this question, taking it. Yeah, that's what I said. Oral therapy is not going to go away. Patients will continue to take it, and we clinicians will need to continue to recommend. But on the other hand, if your patients don't want to take the tablets every day, I think this injectable will be an attractive one. There's another question on on-demand prep. So this is something what has been shown in the CRY 2020 conference, where they have shown every day people taking prep. Probably they may not take it on demand. If you provide to them, it works. Probably that strategy will work. Now, in the context of a long-acting injectable, I think those strategies, need to be, studied in a different way. In oral settings, on demand, you provide them, but here long-acting, the drug is going to be there for 2 months. So that should be studied in a very different settings. Any other questions? I think I assume I have answered all those.
We had a very rapid round. We have more than 10, 15 questions immediately.
So do you want to unmute others if anyone wanted to ask question by raising their hands?
Yeah. So if
still around 70 people are there.
So if anybody would like to ask question directly,
they can raise their hand. They can go to the chat mode and raise their hands.
You can raise your hand and then we can unmute you and then you can ask your question directly to the sir. That's also welcome. If you feel anytime you have any important question to address that, you can raise your hand and then we can take that questions.
Yeah, maybe you should raise your hand so that we can unmute you.
Yeah. I think, sir.
If not, I think we can end this talk, and thank you again for this opportunity. At this time, I thank Emcure, for inviting me to do this presentation, and also I thank Emcure for bringing all those wonderful once daily molecules like TLD and TAF-FTC and dolutegravir. And also, we look forward one day you'll also bring these long-acting injectable when it comes to the guideline, as well as the 2-drug strategies like dolutegravir 3DC. Again, thank you for this opportunity. Please keep bring all those innovative molecules and pharmaceuticals limited setting. Again, thank you very much.
We at Emcure would like to extend our deep gratitude towards you, sir. You were with us for last movie, more than 70 minutes. And we discussed all the aspects of important upcoming scientific data. Thank you very much sparing your time, sir. At the same time, I thanks all the participants across the country. More than 100 participants were there in today evening and listening to all important deliberation done by Dr. N. Kumarasamy, sir. And I would like to assure you, we at Emcure is always strive for scientific events and the scientific content, and we will be a trusted partner with you for bringing new molecules and the combinations and that you have witnessed. So we would like to continue our journey further along with you. And thank you very much, sir, Kumarasamy, sir, sparing your time today evening. So before we end formally, I would like to share one video which is made from Emcure as a gratitude towards all the doctors who are fighting the COVID battle and the pandemic of COVID, which is ongoing. We have initiated this program with the same video. I would like to end this program with the same video and with the feeling of deep gratitude to all the healthcare professionals across the country who are across the globe who are fighting the COVID-19 pandemic. So Vivek, can we start that video, please?
Yes, sir. Thank you.
बड़ी मौत सांसों के पीछे बने तुम जो मसीहा जब जिंदगी में उम्मीदें महावीर खड़े हैं उन सरहदों की रक्षा में जहां आप डटे हैं इंडिया की सुरक्षा में शुक्रिया भारत के है प्यार करे सलाम आपको शुक्रिया भारत के है प्यार करे सलाम आपको है प्यार करे सलाम आपको
Thank you very much. We'll end this program now. Have a nice evening ahead and a happy weekend ahead as too. Thank you very much.
Thank you. Bye-bye.
Bye.